Everybody, under the Step N program of ISCCM, that is the Structured Training and Education Program for the nurses. There's this one topic we are here to discuss. The topic is care of invasive lines. The speaker is Dr. Srivatsa Nagachandan. He is specialist in critical care at Apollo Adlux Hospital, Kochi. So please, Dr. Srivastava, you can continue with your presentation.
Thank you so much, ma'am. Thank you so much for the introduction. Good afternoon, everyone. Today, the topic what I'm going to talk is my one of the dearest topics to me. So it's about the care of invasive lines. And why I specifically choose this topic is, it's because we live in a much more complex world, especially our ICU world is much more complex. It's not as simple as it looks from the outside. And here, the care starts from here rather than stopping here. It starts from here. So it's most of the time it's a continuum between the wards or between the emergency departments and ICUs, or it may be sometimes even discharged to the home. So it's basically a continuum from beginning. So, and why it is complex is because most of our patients are sick, and these are the sickest patient cohort in the whole of the hospital itself, and they move less, and most of them they are malnourished, they are uptended, and they even do have multiple comorbidities. Multiple comorbidities in the sense mean that they may be having like diabetes, hypertension, kidney disease, chronic kidney disease, chronic heart failure, all sorts of colors and flavors you can see in the ICU. So that makes the ICU world much more complex. And the term ICU itself says that I invasively care for you. And when we do care invasively, I'll come to that why I said invasively, because any patient who is sick enough in the ICU will be requiring some sort of an invasive line into them. Either it could be in the as simple as a rice tube, or it could be a urinary catheter, or it could be a central line, or it could be an endotracheal tube, or it could be an ECMO cannula, or whatever. We generally care most of the ICU patients invasively. And when we do that, we need to keep in mind 4 important aspects, because whatever we do, we need to have a strict observation skills, because we need to know what we are doing. And second thing is we need to intervene when there is a problem happening. Like example, if you are in the sense of observation, you need to know the clear-cut indications about why we are putting in Foley's catheter or a Riles tube. And even if you are doing that, you need to be making sure that how you will be monitoring them. And once you're monitoring, you may be finding out they have a sinusitis or they may having a CORT or something like that. Then you need to communicate between your team and then report it appropriately to the ICU nurse so that the loop is maintained. So that's the reason most of the time what we do in ICU is invasively we care for you. And the more the invasive lines and the more the surgical patients and the longer the length of stay, and more IV and parenteral drugs will be required. And if the more and more these things are required, then obviously you'll be tube feeding them, or you may be requiring a temporary parenteral nutrition. And most of them, if they are sick enough and they can't breathe on their own, you definitely need a ventilation in the form of an endotracheal tube, or non-invasive in the form of an NIV, again, which can even cause pressure sores and other stuff. So whatever you're doing from outside, be careful about what you're doing, and then keep monitoring them and observe them, and then intervene whenever certain things are harming them. Intervene at that point so that that harm is prevented, and then communicate and then report. So that's the loop. That's how the closed loop works. So if you're doing something, there should be always a purpose. As I told you, if you're putting a central line, there is a purpose. Means either you need to give some fluids, or you need to give some very much caustic substance like amiodarone, or it could be in the form of TPN. So there is a purpose. So with every purpose, there comes a consequence. You can have the purpose, but you can never have any control of the consequences. So why I just like to quote this quote, that we are free to choose our actions, but we are not at all free to choose the consequence of our action. So for that reason, you should be, all of our nurses and all our colleagues should be very much stringent with respect to the indication for use of any invasive line. It could be a central line, or it could be as simple as an urinary catheter, or it could be a Foley's catheter, or it could be a Riles tube. Whatever thing which you are doing, putting inside the patient's body cavity, you should have a proper indication to that. And whenever you are putting into that, you should follow proper procedure, even at the insertion as well as during the maintenance. And all this thing has to be adhering to the infection control practices. And most of the time, don't forget the last and the least, prevention. Prevention also includes that whenever the line is not necessary, you need to remove it. Otherwise, it will have its own consequences. So before dwelling deeper into the care of invasive lines, I just like to highlight few general principles in the care of tubes and lines. It applies to most of the things, most of the stuff. It could be an ICD, even intercostal drainage tube, or it could be, as I told you, a rice tube for feeding the patient. So understand first and foremost, one thing is our body cavities are closed, and once the closed cavities, there is a closed cavity, most of them are sterile. There are exceptions, however, but closed cavities of the body are most of the time sterile cavities. And insertion of any tube or any line must be performed with adherence to the principles of sterile asepsis. And once you breach that cavity, or once you make a portal of entry that comes into the contact with the non-sterile surface, immediately renders an otherwise sterile field non-sterile. Means if you put a line, then obviously you're making a pathway for the bacteria to go inside the body cavity. So that means the sterile part eventually becomes unsterile, right? So that is what is happening. So it could be when disconnecting the drainage tubes, such as urinary catheter or a endotracheal tube, the ends must be always should be kept sterile. And third most important with respect to this thing, tubes and lines, is gravity. Gravity promotes the flow of drainage from a cavity. Means keeping a drainage tube or collection bag at a lower level than the cavity being drained always helps in that. And position of the tube so that the drainage will not have to run upward. If anything, if you put a Foley catheter above the patient's bed height, then obviously instead of flowing the urine out, it will be going in. So that is not good thing, because the fluid which has come out is going back in. So that's not a good thing. It always should go, it should always come out. And the fourth most important point is drainage will flow out of the tubing only if the lumen is not occluded. So that brings us to the most important one thing is avoid kinks or coils in the tubing. And was that the person does not lie on the tubing, because this happens most of the time, especially with respect to intercostal drainage tubes, ICD tubes, which we put to drain the blood or fluid from the thoracic cavity. So what that happens is most of the time patient will be lying on the tube, and that poses a risk for dislodgement and as well as increased risk of infection. And also the most common practice what I have seen is clamping the Foley's catheters or clamping the ICD tubes. If you look at the evidence for that, there is no strong evidence to that. And as per the literature review, I understand that it is not advisable to clamp the tubes without a proper indication to do that. And whenever you are doing anything, properly cleanse the site before accessing any tubing to reduce the possible introduction of microorganisms into the cavity. As I told you, body cavities are sterile, so clean them before using them. And sometimes contrast media or radio pharmaceutical drugs, especially in oncocritical care, are injected via the tubing. And an alcohol swab may be used to clean the entry point prior to the accessing the tubing, so that you will reduce the risk of infection. So these are the 5 most important general principles. And out of this, one of the most important points which I would like to highlight is kinking. This is why I'm stressing on this thing is everybody knows, because they will be listening to most of the classes and they understand the infection control practices. But most of them at the bedside, the commonly missed thing is kinking of the catheters. It could be, as it showed in this picture, it's an intercostal drainage tube. So it can be kinked especially when it is completely attached to the patient on the other side, and if not monitored, it can get kinked. And same thing can happen even with the central lines, or same thing can happen even with the Foley's catheter, or even the Rice tube. So whatever devices, make sure that you inspect from the point of insertion to the point of exit, so that there is no kink anywhere. And second important thing is with respect to Foley's catheter and intercostal drainage tube is keeping the position lower at all times. Even when you're transporting the patient, I have seen people keeping that Foley's bag or other things onto the bed. Please don't do that, because you're pushing the organisms back into the sterile cavity. So always try to keep the position lower at all the times, whether it is a Foley's catheter, whether it is an intercostal drainage tube, or it's any drainage bag. It could be like a post-op patient who has multiple drains in situ. So you need to try, you should always keep the drainage down, because the main purpose of the drain is to let it out, not to get it back in. Okay. I hope everyone is listening. Everybody is not sleeping, right? Okay. So let me move further. So as I told you with my topic care of invasive lines, any central line or any other invasive device, as I told you, it disrupts the integrity of the skin and as well as the mucous membranes, making a portal of entry for the infection and making it more possible. So what sort of infection I'm talking about? It's most of the time nosocomial infections. So how does it occur? As I told you, we care our ICU patients more invasively. So that means we put them on lot of devices. It could be in the form of renal replacement therapy device, a dialysis machine, or it could be IC intercostal drainage tube attached to outside, or it could be a central line to give medications and antibiotics. So all sort of devices we use, or it could be a ventilator with an endotracheal tube. So all sort of devices. So it could be because of, as I told you, whenever you breathe the entry, so obviously you're making a portal of entry into the sterile cavity. So that is first and foremost problem with respect to the increase in risk of nosocomial infections. Second thing is hand hygiene related, especially healthcare workers. I'll come into that in depth in the later of my talk. And third and most important factor is patient care and environment related, especially when you are taking care of Foley's daily routine care. You should be very careful that you don't introduce infection into that. So you should be from inside to outside. It should not go from outside to inside when you're especially cleaning the sterile parts. So these are three important factors related to the nosocomial infections. And coming to the indications, there are lots and lots of indications for each and every device, and it's beyond the scope of this talk. But I'd like to highlight two important things. One is central line. Why do we require central line? Why do we require central line? Central line is required because of fluid resuscitation, one thing, and we need to infuse certain drugs which are very much caustic to the peripheral veins. And second thing is when you need to give some certain blood products and other things faster, or you want to give total parenteral nutrition and sometimes even transvenous spacing where the heartbeat is not proper and the cardiologist asks you to do a pacing. So that is when you require a central line, or when there is a difficulty in getting a peripheral access line, and sometimes very rarely for CVP pressure monitoring. That is a more comprehensive indications of central line. What about Foley's catheter? Foley's catheter, I think most of my all the nurses will be very much familiar with the common mnemonic Houndy, right? So what does it mean? So I'm not going to the Houndy in the format, but in the most necessary format or most indicated part, first and foremost, we do put Foley's catheter while to check the fluid balance. And second thing is, whenever there is any urological procedure is planned, or patient is having any sort of hematuria, or the patient is having any sort of urinary obstruction. So in order to drain it out, we generally put the Foley's catheter. And some other few indications in the ICU is comfort care, especially during the end of life care. You don't want them to get wet and then cause a discomfort, rashes, and other sort of stuff. So you do Foley's catheterization electively in them. And in patients who are already having the pressure sore, like around stage 3 or stage 4, in order to not to make it worse, and in order to improvise the care, you generally Foley's catheterize them. And in case of trauma, especially when there is an unstable spine injury where immobilization is imminent, there also you use Foley's catheterization. So these are the predominant indications for central line and Foley's catheterization. However, there are indications for even endotracheal tubes as well. Like why do we need to intubate? It's a $1 million question, but still we do that because in order to protect the airway, or the patient requires oxygen which they are not able to maintain with their native lung ventilation. So in order to do that, you need to put an endotracheal tube down their throat so that you can ventilate them and provide more oxygen to them. And in the same way, it goes to the rice tube also, feeding tube, I mean to say. Means if the patient is not able to take food appropriately, like example, patient who is intubated, or patient who is taking food but not in an adequate way so that their nutritional goals are not met. So there also you can think about feeding them through a tube. It could be nasogastric or it could be nasojejunal, depending upon the consultant's preference. So these are the brief indications about why we need to have certain invasive devices in certain patients. So these are the different sort of tubes. First and foremost is definitely you all be knowing. It's a Foley's catheter. Second thing is endotracheal tube. And third one is a tracheostomy tube. And fourth one is a drainage bag, which we see most commonly in our surgical ICUs. And for fifth one is, as you can see, it's an intercostal drainage tube put for draining the pleural effusion or empyema or whatever pus which is collected inside the thoracic cavity to drain it out. Okay. So coming to the next step of caring of the invasive lines, as I told you, indication is one part, and second part is how you do the procedure. You need to do it in a utmost sterile manner. So what all you need during insertion? You need to have the cap, you need to have the mask, you need to have a sterile gown and sterile gloves. And also, one more important factor is you need to choose an appropriate size catheter for that appropriate age. Example, you can't put an pediatric cannula into an adult patient or adult cannula into a pediatric patient, right? So you need to choose a proper size. Otherwise, what will happen? The risk of thrombosis, especially with respect to cannulas, increases. And that increase in risk of thrombosis leads to increased risk of infections and fever and prolonged length of ICU stay. And coming to the location, where exactly you need to do, there are certain procedures which can be only done in the OT. And there are certain or most of the procedures which can be done only in the ICU or in the ED. And there are only minimal procedures which can be carried out in the ward. So you should know appropriately where to do a specific procedure. Like Foley's and catheterization can be done even in the ward, right? And central line cannulation can be done either in the OT or in the ICU, right? And even in the ED, provided they are able to do it in a strict aseptic precautions. And you need to select even the proper site of insertion, like especially if going with the central line, you should be aware that there are different sort of central line insertion sites, like internal jugular is there, subclavian is there, you can put the femoral lines, right? But which is the most more important and best way to prevent infection? Anybody from the audience? No? Am I audible, Deepa?
Yes,
Deepa?
yes, you are.
Yes, sir.
Yeah, thank you. So the subclavian line would be much more better in with respect to central lines in preventing the infections. I think everybody is sleeping, or I don't know. I mean, this is first class, so I thought of making it interactive. Anyway, and don't forget this thing is obtaining the consent. Never ever forget to obtain the consent. Always look into that whether consent is taken or not. Once all these things are decided, then you need to do the skin preparation. As I told you, when you are preparing for the skin, you need to go it from inside to out. Once you go out, you should never come back inside and put it up, because that makes the area sterile, unsterile. So skin preparation is currently recommended as per the series with either using 2% chlorhexidine or povidone iodine. But the problem with povidone iodine is it takes roughly around 2 minutes to act. So you should be knowing that povidone iodine takes around roughly 2 minutes. But as 2% chlorhexidine, 2%, I'm again saying 2%, not 0.5%. 2% chlorhexidine, it acts within seconds. But only drawback with that is when there is a blood stain, so it's a bit difficult. And another thing is no shaving, only clipping before the procedure, especially if there is a huge beard. So you should be very careful, because shaving increases the risk of infection, because there will be micro cuts and that leads to the risk of infection. So always clip and no shaving, because I've been even seeing that especially when transferring the patient to the cath lab, they always shave the femoral areas. That's not a recommended practice as per the CDC, because it increases the risk of micro cuts, and that micro cuts makes the entry or portal of entry for the infections. And another important part is hand hygiene. Never ever forget hand hygiene. Before doing any procedure, wash your hands, and after the procedure again, wash your hands. There are 5 moments of hand hygiene. I'll be coming to the next slides. And before doing anything, always explain to the patient, because that is much more important. Before beginning the procedure, tell them. That reduces their anxiety and improves their cooperation with you. So that means you can do the line at a much more easier. Not only lines, it applies to any procedure, even it is Foley's, even it's right tube insertion, or any sort of a procedure you are doing on a patient. Even it's as simple as inserting a cannula. What about maintenance? See, again, coming to the maintenance, you need to maintain sterile, transparent dressing. It should not be a completely non-transparent dressing, it should be transparent one, and the underlying line should be properly visible. Okay, and you should regularly inspect the insertion site for local signs of infection and inflammation, like whether there is a redness or whether there is a pus oozing out from that point, or is there any leakage around that. Whether with respect to central line, it could be bleeding, it could be pus point, it could be redness. With respect to foliage, the urine may be draining, instead of draining through the catheter, it may be leaking around the side. So all those things you should be regularly watching around and inform the respective doctors as and when required. And with respect to peripheral cannulas, see, even I'm saying invasive means even it comes peripheral cannulas as well, because without a cannula, you can never care, right? Cannula is a basic foremost thing in any ICU. So whenever you're using peripheral cannula, also use a scoring system, especially to monitor for the thrombophlebitis thing. And as I told you, choose appropriate size. Now, with the advent of ultrasound, and as ultrasound is more frequently available in the ICU, we have been training our nurses to even look at the insertion sites, especially peripheral venous cannulas, to look at the specific vein and then look at it, whether this much of cannula is able to get into that, or whether that vein is able to accommodate. If the cannula is accommodating more than 3/4 of the vein size, the risk of thrombosis increases. Okay, so you need to be monitoring that as well. And second thing, as I told you, before doing or after doing, always, 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 never ever forget the fundamental of all this whole of care of invasive lines is hand hygiene. Never ever forget hand hygiene. And before choosing any port to give any medications, or to collect a urine sample, or before feeding or anything, clean the ports of entry before and as well as after the use. And this applies, more important is especially with respect to the central venous catheters. But don't forget that it applies even to the other aspects also as well, even Rice tube, or it could be Foley's or anything. And change the sterile dressing as per the hospital policy. Our policy is generally to change once in 3 days sterile dressing, or if it has been soiled, or there is a problem with that, then change as and when required. So that is our hospital policy. So do check with your hospital policy and then change it accordingly. And remove the devices as and when it's no longer necessary. As I told you, if the patient doesn't require a Foley's catheter, remove it. Don't try to go and clamp it and wait for 2 hours and then remove it. Just remove it. If the patient has any problem, he'll obviously tell you, because clamping will not change any of the things, especially with Foley's. So just remove it. Even with respect to ICD also, don't clamp it. If the drainage is less than 3 ml per kg per hour, just remove it. If the collection is coming back, you can obviously know, you can re-put it again. I understand when I'm quoting this, there are risks involved, but you need to bear the risk and then do the things. And there are specific device related daily case and maintenance of closed system in certain situations. Like as I told you, especially with respect to ECMOs, or especially with respect to Foley's catheters, you can't just leave it out there. You need to give the daily care by cleaning that area. And cleaning right now, there is strong recommendation only for soap and water, and even plain water is sufficient for cleaning the Foley's or any other genital areas. That's it. There is no specific that you need to use only povidone, iodine, or iodine. Okay, and don't use chlorhexidine in genital areas. So you can use just soap and water to clean that area and maintain the daily care. And always follow the bundle of care, because there are a lot of things, lot of invasive devices which we use. So follow specific bundles of care for that specific device. Like for central venous catheters, there is a central line care bundle. So follow that bundle. For endotracheal tube, there is a VAP bundle. Follow that bundle. And for Foley's, there is a Corti bundle. So follow that bundle. So whatever the bundles is there, you need to follow that. And always make sure that you don't drag, or you don't tug, or you don't pull on the catheter. I will always watch for that. So few brilliant minds got this concept of bundles of care. So you'd also heard me saying bundles of care. So what does it mean, bundles of care? See, it's basically a set of interventions that we do together, so that at the end of the day, it improves significantly the patient outcomes. Because small things, what we do will eventually add up, and that gives us a better outcomes. So multiple disciplinary teams work together to deliver the best possible care, supported by the evidence-based research. That's the reason what I'm saying is clamping is no more recommended. It's not no more evidence-based, and practices with ultimate outcome of improving the patient care. So let's dwell into one by one bundles of care. So first and foremost, before going into that, this is an important slide. Take a note of it. There are 5 moments for hand hygiene. One is before touching the patient. Second is before clean or any aseptic procedures. Third is after body fluid exposure or after the procedure. And fourth is after touching the patient. And fifth is after touching the patient's surroundings. Everybody remembers the first 4 one. Everybody forgets the last one. Even after touching the patient's surroundings. Like example, you're on the rounds, you're touching the patient file. After touching the patient file, do wash it. Even though you can say, I have not touched the patient. No, you have touched the patient file. You have touched the patient's surroundings. So you need to do hand washing again with chlorhexidine. So coming to the each and every bundle. So first we'll go with the central line bundle. So before insertion, as I told you, you need to wash your hands with following the 6 steps of hand wash. And once you've done that, you need to wear the maximal barrier precautions as I showed in the second picture of mine, wearing all the stuff, cap, mask, gloves, and gowns, and even shoe cover in certain patients. And then once it is done, you need to the skin antisepsis, either using 2% chlorhexidine or povidone iodine. And then you need to apply the full body drape. And once you've done that, once your procedure is completed, apply the sterile dressing, transparent dressing, and daily review the site, especially central line site. And make sure that the optimal catheter site selection and avoid femorals most of the possible in adults. Subclavian is the best one, but if subclavian is not possible or an institution doesn't allow you to put subclavians or it's not possible, then go for the internal jugular veins, but avoid femoral and keep the femoral for the last thing. And whenever you are doing the maintenance, always before injecting any drugs, scrub the hub. So that is one of the most important thing. So wash your hands, do a 15-second hub scrub as I shown in second picture, and then once it is done, just allow it to air dry for 3 seconds, and then connect or give whatever drug you want to give. And then once it is done, completed, then again do the same thing, scrub the hub, allow it to dry, and cap it. So that is how you need to do it with respect to the central lines. So I'm just going to ask few questions to the this thing. What do you see in this? What is wrong with this picture? Audience, anybody? Anybody can is there anything wrong in this picture? Okay. No response?
No response.
Everybody is sleeping.
You will have to answer.
All the nurses are sleeping. All my nursing colleagues are sleeping. No one? Okay. So the problem is there are a couple of problems in this thing. One is it's not properly flushed. As you can see, there is a blood inside here, which is you can see here in the catheter. And second thing is catheter is put out significantly out, and the dressing is completely soiled, and there is a nasal oxygen mask which is going on top of that. So these are all the things which we should avoid doing whenever you're caring for a central venous catheter. So first and foremost, you need to insert the catheter fully inside so that nothing remains out, and always flush the catheters so that blood doesn't remain inside the catheter. Blood is a culture media. It makes the bacteria grow. Okay, so always try to flush your catheters after every use. And once there is a soiling, always change the dressing. Don't try to keep the dressing same way. And what is the problem with this second picture? I hope nobody is going to answer anyway. I'll answer it. So again, here you can see the blood which is clotted inside the catheter. It's not properly flushed, though it is properly sutured with no much of things seen outside, but still even the dressing is not properly stuck. So there is a dressing which is coming off, and that is causing a pull and drag over the catheter. So that will cause patients pain, and as well as the pain, they try to stick it on their own, and that increases the risk of again infections. So these are the 5 moments of hand hygiene, especially when you are focusing on caring for a patient with a central venous catheter. So this I have modified the same 5 moments of hand hygiene which I showed you in the beginning, the same thing, but especially with respect to the catheter. So before insertion, again, you need to hand wash. After insertion, you need to hand wash. And whenever you're caring for the catheter, you need to hand wash. Whenever you're touching the patient surrounding, irrespective whether you're touching the catheter or not, you need to hand wash. So make sure that you have proper indication before putting a central venous catheter and adhere to the maintenance and as well as removal bundles. And never ever forget, scrub the hub before using it with alcohol-based chlorhexidine for at least minimum 5 to 10 seconds, 15 seconds minimum. And whenever there is no need for the catheter, remove it. And this applies even to the peripheral venous catheter also. This is specifically, I'm bringing this topic because most of the people think peripheral venous catheters are not damaging, but it can be damaging when you have a multiple pokes in a patient with multiple this thing. Especially we see when the patient comes from the ward, they'll be having multiple pokes, multiple places, they'll be having a thrombophlebitis, and that eventually leads to infection. Yeah. So make sure even your peripheral venous catheter you care exactly as you care for a central venous catheter, because you're putting something inside the body cavity. So the same principle applies here as well. And coming to the endotracheal tube, as I told you, there is a VAP bundle. So make sure that you follow this thing. First and foremost, you need to make sure that all our ICU patients who are intubated have a head and elevation, and you give them proper oral care with chlorhexidine, or even simple plain water also is sufficient. And stress ulcer prophylaxis in the form of pantocid or ranitidine or whatever, make sure that that is given. And you can follow either daily breaks in sedation or protocolized way of giving a sedation, either of that. And make sure that all your patients get a deep venous thrombosis prophylaxis. And educate the patient and as well as the family, because most of the time we doctors will be rounding multiple patients and taking care of multiple ICUs. Nurses, you being nurses, you are gifted because we'll be with one patient dedicated. I understand that 1:2 nursing ratio is there, but still, patient family, whenever they come, they rely on you much more than anybody else, because they'll be giving their loved ones to take care by you. So make sure that you take that responsibility very well. And the use of disposable catheter for each suctioning, or use a closed suctioning, which can be changed in once in 3 days or once in 7 days, depending upon your hospital policy. And perform orotracheal suction before deflating the endotracheal cuff, especially when extubating. And change ventilator circuits as per the hospital protocols. And adherence to the hand hygiene protocols and aseptic precautions even continues here. So general principle is that hand hygiene is a must in any prevention care. And this is how, again, I have modified it for the endotracheal tube. The same principle applies here as well. And these are the key additional considerations for any person with an endotracheal tube. Avoid intubation as much as possible and use non-invasive, but don't delay it, and do it whenever it is appropriate. And if you have done it, take care of that thing with proper VAP bundles and proper suctioning. And the same principle even applies with the Foley's catheter as well. It's again the same. You generally study one principle and apply it to the different patient as per that patient's lines and tubes need. It could be an even ICD tube also. You need to take care of them in the same way. So remove it as and when necessary. So let's go with the journey of one of our hand hygiene, and why I'm saying it is important, and the journey of a surgical patient. So if you look at the surgeries, there are 313 million people undergo surgery. And I was quite surprised before preparing for this talk, was because it is almost twice our birth rate. And patients get admitted to the hospital or a clinic, and that itself increases the risk of colonization with the germs. And again, here the hand hygiene comes. You need to wash your hand before you're taking care of the patients. And once you put pre-op optimization like central lines or urinary catheters or whatever stuff, again that breaches the barrier and increases the risk of catheter associated infections. And then again your moments of hygiene, hand hygiene comes into play. So you need to use your chlorhexidine, wash it, and then the patient may go to the operating theater. And there again, as I told you, before performing any surgery, you need to wash your hands properly and wear the proper universal precaution measures. And then once the surgery is done, the risk of surgical site infection increases. And once that patient is shifted to the post-op recovery, again the lines and tubes are cared for, again our moments of hand hygiene comes in. So these are the areas where you need to be very careful, because you need to do that. If you don't do that, the patient will never ever get discharged to their homes. They'll be circling around in a hospital. So that's what happens. So patient, if that moment of hand hygiene is not taken care, the patient will not leave the recovery room. If the patient doesn't leave the recovery room, the patient will not get discharged. But if you have done that appropriately, and if you do see your hands and wash it and do the dressing as and when required and doesn't open it unnecessarily, then again the patient is high likely going to get discharged without any risk of infections. And if you see in surgical things, almost up to 31% of the patients get surgical site infections. And even when I looked into the data, 61% of our healthcare workers doesn't won't clean their hands at the right moment, because they don't know when it is the right moment. So you don't be that sort of a healthcare worker. You do hand hygiene at the right moment and follow the 5 moments of hand hygiene. And 1 in 2 surgical staff, this is also as per the research, 1 in 2 surgical staff do not clean their hands at the right moment. And all this will lead to the length of stay. And it increases by almost 3 to 20 days, and with increase in risk of surgical site infections. So the key consideration for post-operative wounds is avoid unnecessary touching of the post-operative wound site, including by the patient. Tell the patient, educate the patient and family members, don't touch it unless and until it is necessary. And wear gloves if contact with the body fluids is anticipated. The need for hand hygiene does not even change if the gloves are worn, as per the WHO's 5 moments. And follow the local procedures. And don't touch the dressing what the surgeon has done for at least 48 hours, unless and until there is a leakage or soakage. And routine post-operative wound dressing should be basic dressing type, like an absorbent or low adherence dressing sort of a things. And whenever there is no necessary for the drainage, ask your surgeons or your doctor whether it can be removed. You need to be the person who gives the hint. Sometimes we also, being doctors, forget things. So intimation from your side is always welcome. So we all work as a team here, rather than one being higher or one being lesser. And I was dwelling why this hand hygiene is a problem. Why, even despite not me taking, but a lot of people taking these classes, but still the prevalence of hand hygiene is still lesser. When people don't do properly hand wash. And this was one of the pictures which I got it from the CDC. So if you look at the points in the hand, thumb and the tip of the fingers are the most often missed areas. People don't even think that that infection can reside there. And next often, most commonly, is the wrist and the fingers, especially the index finger and the middle finger is the one which most of the time is next oftenly missed. And the least oftenly missed are the palm of the hands and the dorsum of the hands. We do properly over there, but we most of the time forget our thumb and the tip. So why does it occur? I was dwelling deeper before giving this talk. So what I understood is it's the problem of hand hygiene, or the lack of promotion of hand hygiene. It's actually, as I told you, we all work as a team. It's not one individual's problem. It has to come from the institution. I mean, the safety thing has to start from the institution, and more than institution, the individual has to internalize it. That whenever I'm taking care of a sick patient, it could be one of my next kith and kin as well. So I need to wash my hands before taking care of them. So one need to internalize it. Once that institutional change and internalization of the person doing it happens, obviously the system will change. Once the system changes, more and more training and education happens, and more reminders in the workplace will happen, and more it happens, the more and more feedback and evaluation happen, and the more and more hand hygiene promotion will happen, and that will eventually reach to 100% compliance with the hand hygiene. So that is the basic fundamental things. So what are the barriers to this effective hand hygiene? First and foremost is jewelries, especially rings with stones. So these are the one of the barriers to the hand hygiene that will prevent you from having a proper hand hygiene. Second thing is nail varnish or false nails, which we don't recommend, and know, as of I have seen, none of the healthcare professionals do have this false nails, but still you need to be aware of that. And second thing is watches and wristbands, especially the bands are the one thing. And third thing is long sleeves, especially when you're having long sleeves. So these are the barriers to the effective hand hygiene. And this is another one quite interesting study which was done in ICU nurses. It, they roughly analyzed around 3,200 hand hygiene opportunities among 64 ICU nurses in 4 different hospitals in Texas, and they were overtly observed. And if you look at that hand hygiene data, 20% of the missed opportunities were accounted for the 4 most important activities, like either the nurse is carrying something, or they're donning the gloves or doffing the gloves or wearing the personal protective equipment, or they're pushing the trolleys or pulling the workstations, or they're using the mobile device. Even not only nurses, it was applying even to the doctors as well. So that was one of the reasons why there was a poor compliance. But at the same time, the study was more intriguing to me, because if you look at the people who had uh, almost 90 to 100% compliance in the high hand hygiene. And if you ask the reason for the compliance in high performers, the first and foremost was internalization. Means all those nurses understood that if I am caring for my own beloved one, I'll not be doing this. They internalize that concept, but that whenever I'm taking care of an individual, I should be doing it with utmost care so that I don't spread the infection to them. So that was the first and foremost thing. And second thing is previous exposure and desire to avoid the repetitive risk. That was another thing, means where they got adequate training. And third thing is prior perceptor and advocated compliance, means people have been advocating that you need to do it, you need to do it. So that's when they did it. And another was fourth one was most important one, incentives, which we all is necessary, because at the end of the day it is money which matters. So bonuses and pay raises boosted the compliance, especially in high performers with respect to hand hygiene, and that even included later on even the people who are not compliant as well, when they did further prospective analysis of the next batch. And even pregnancy and concern of the unborn baby was also the reason in for compliance in high performers. So what we can take one message from this thing is, whenever we are encountering with a problem, we should always find ways to deal with problems rather than running away from it. So especially with respect to hand hygiene also, it applies the same. So I'd like to end this talk by saying that caring hand should be always the clean hands. And if there is an interaction, I would like to take a few MCQs. Ma'am, Priyanka ma'am, is that okay? Priyanka ma'am?
Sure, Dr. Srivatsa, you can always take
Yeah. I would like to have an active participation from all the nursing team, my nursing colleagues. So, okay, what is the recommended frequency for changing the dressing on a central venous catheter in ICU? I'll be giving you 1 minute time. You can either put the thing in your in the chat box if you're afraid to open your mic and say it. I'll definitely give you a minute time. So what is the recommended frequency for changing the dressing on a central venous catheter?
An answer has come in the chat box.
Okay. Okay. So the answer, so I go with the answer, or should I give one more time, ma'am? Little bit of a time?
Yes, you can give.
Yeah. Daily, every 3 days, weekly, only when it appears soiled. I know I have been making it more difficult, but it's quite fun. Okay. So the answer is actually once in every 3 days. But again, as I told you, it depends upon the institutional policy. And you definitely need to change your dressing when it appears soiled. So that is the reason it is not the answer. And next question. So which of the following is the preferred method for securing an endotracheal tube in the ICU to prevent dislodgement? One, tape. B, silk suture. 3, commercial tube holder device. 4, no securing is necessary. Okay, you get your time starts now. Think we are playing Kaun Banega, Crorepati sort of a thing. I hope answers are coming out in the chat box. Okay, the answer is C. Commercial tube holder is always recommended. So don't just try to put a tape or any silk suture over there. And no securing the endotracheal tube is always obviously more riskier. So next, coming to the next question, when flushing peripherally inserted central catheter PICC line in the ICU, which solution should be used to maintain patency? Option A, sterile water. Option B, normal saline. Option C, heparinase saline. Option D, sterile alcohol. You get 1 minute to answer it. Hope the answers are coming out in the chat box, I believe, but I couldn't see it. Anyway. Okay.
Yes, few answers have come.
The answer is heparinase saline. So that is the best one. But again, normal saline is also not a bad option.
Yes.
And coming to the next question, which of the following action is essential to prevent bloodstream infection related to central venous catheters in the ICU? Sorry for being faster. Option A, routine replacement of central venous catheter every 72 hours. Option B, daily administration of prophylactic antibiotics. Option C, proper hand hygiene and aseptic techniques during central venous catheter insertion and maintenance. Option D, frequent use of silver coated central venous catheters. So time starts now. I'll give you 30 seconds. I hope everyone answers this thing correctly. Okay, so the answer is C, proper hand hygiene and aseptic technique during central venous insertion and as well as during maintenance. So coming to the next question, what is the recommended position of the patient's head when managing a subclavian central venous catheter in the ICU? Option A, neutral position. Option B, Trendelenburg position. Option C, head elevated 30 degrees. Option D, head rotated to the opposite side of the central venous catheter insertion. Quite a tricky question. Okay. The answer is neutral position. It's a subclavian catheter here. Why you want to change the head?
Everyone, I think, got it wrong.
It's a subclavian catheter. It's a subclavian catheter. Why you want to change the head position? So it's anyway, it's in the chest, so you don't have to change. Okay. So I'll go with the next question, couple of more. I hope I'm not boring anyone. I wanted to make it more interactive. Okay, so the next question, to reduce the risk of ventilator associated pneumonia, VAP, in the ICU, how often should the endotracheal tube cuff pressure be monitored and maintained? Option A, every 12 hours. Option B, once a shift. Option C, continuously. Option D, only during the routine endotracheal tube change. Your time starts now. This is the most simple and straightforward answer. Sorry. Okay, time's up. So the answer is only once in every shift. So ideally, recommendation is to make it, check it every 8 hours. Thank you.
It was an excellent presentation, Dr. Srivatsa, and a very
Thank you, ma'am.
extensive one. You covered each and every point, and
Thank
it was
you.
wonderful. It was wonderful hearing you.
Thank you.
Okay, now
If anybody has
Yeah.
any questions, I'm ready to
Yeah.
take it.
Thank you, sir. Thank you, ma'am.
Thank you, Deepa. Thank you.
thank you.
We can end the session.
We can end the session. Any questions?
Actually, questions are asked in chat box. There is any questions?
Any questions?
No, sir. In chat box, there is no question, sir.
Okay.
Okay. So with your permission, I'll end the session, sir.
Okay. Thank you, Priyanka, ma'am. Thank you so much. It was
Okay,
nice.
thank you. Thank you.
Thank you. Bye.
Bye.
So first, somebody has asked some questions. So first two questions I want to answer. First two questions. Okay, just a minute. First question answer is once in every 3 days. Once in every 3 days. And the second question is commercial tube holder device. I mean, there are tube holder devices are available, but I'm not sure whether it is widely available or whether cost is an issue. But there are ET tube holder devices are available. Okay, he's asking, I want the question, sir. Okay, you want the question. Okay, so what is the recommended frequency for changing the dressing on a central venous catheter in ICU? Option A, daily. Option B, every 3 days. Option C, weekly. Option D, only when it applies, only when it appears soiled. I hope you got that question, Rupa. That was the first question. And the second question was regarding the endotracheal tube, a securing of an endotracheal tube in an ICU to prevent dislodgement. If possible, I'll share my PPT to Deepa, so you can, if you want, you can collect that thing, even the MCQ questions. I can do that. Deepa, that would be okay, right?
Sir, on Facebook and YouTube, this video is also available. So
Okay.
participant can watch that from there only.
Okay, sure. I hope Rupa, I think one of the sisters was asking the same. I think she got the answer. Yeah. Okay, ma'am, then we'll conclude.
Okay. No,
Thank you so much.
Okay, thank you. Thank you for the wonderful presentation.
Thank you.